audible?
Yes.
Okay. Okay. A very good evening to you all. Welcome you all to the apta webinar series. So today is the third class on parasurgical procedures, and today's class will be led by a very dynamic and committed Dr. Sreejith. There is no need to introduce him. He's very familiar to us. And today, Dr. Abhishankar Parvaje had agreed to moderate the event, but due to some personal inconvenience, he won't be available today. He will join us in the next class. So with much joy and respect, I invite Dr. Sreejith to commence the session.
So I think we just start.
Okay.
Yeah. I have made sure that we. But is the screen audible? I mean, visible?
Yes.
Okay.
Yes.
All set. So I put a star mark there. Anyway, namaste to all of you. Some of our friends would join later. So I will make sure that you are engaged and they don't lose many of the things either. So anyway, if you see very clearly enough that part 3 and A star. A star is deliberately mentioned. It's a slight deviation from the original schedule because when I was preparing a slideshow and all the points, I realized one session may not be enough. So let us see how it goes this one, and maybe we need a second part of it. But that's the reason put A star. As always, I would say I'm still a medical officer, but on leave, Government of Kerala. And the reason of using that Government of Kerala is that we come across people, all of us, medical officers, we come across people who don't earn more than 10 to 15,000 rupees or maybe even 20,000 rupees a month. So we are dealing with people whose economic purchasing power or capacity is not really high. That is my reason of putting there, which means these procedures are very much applicable even to the so-called economically poor class of people. The second thing to mention is the website you see from drthreya.com. The reason is, as I had mentioned before too, just having come across people from 104 different nations, which means they came to us because the existing medical system in their country was unfortunately not helping them. This is a reason they came to us, and not that we were successful every time, but most of the occasions we were successful. And that was possible because of many simple and effective techniques that we do in our place. We call it a medical resort. Medical because all kinds of inflammatory, degenerative conditions comes to us, and we call it resort because very cozy, clean, very, very friendly, garden-like environment we maintain. So the reason of telling that here is many conditions which are not very satisfactorily dealt by allopathy are dealt very effectively by parasurgical methods. This is why I mentioned both my identities, and this I have spoke before. Before we go forward, I would kind of caution you that there are at least 7 or 8 slides which are repetitive in nature. But as mentioned last time, also I'm having the same opinion now. There are many of you who may be coming for the first time to this sessions, so it's important that you feel at home and at ease and at same page, which all of us are since the last 2 sessions. I think before we start, something very, very important that can have the potential to have a lot of impact in your professional life and clinical life, and also to the lives of patients who are suffering. We must start with somebody very humble and very great as Dr. APJ Abdul Kalam sir. Always, he's in our thoughts as inspiration. And as like last time, your benefit in the next 1 hour would be to handle with confidence and to get convinced that this is something that you can do also. And most importantly, that you feel, yes, I'm starting Sringam from tomorrow, very next day. This is what we exactly aim out of the sessions from AMI's, if I may call it online training, if I can use that word. And if we have a scenario where our young doctors get into it at a very early part of their career, I think that's ultimate success of the entire series. So this is, well, I put 1 hour, but it may extend to another 15 more minutes. We will see how it goes, for at least 1 hour. So here, somewhere in 2000, I was a final year BMS. And as you see, why I use the word 2000 and I use the word textual reference is simply because Agreed, you study this in your shlokas and and all kind of theoretical narrations. Agreed. And I've highlighted Haret Shringa the Bihi. Agreed. And Vada the Dhamva Shringa Jaluka is coming. Let us keep that up. But that Shringa, it ends like a half shloka. Uh, Half shloka that you see, and two lines above that you see kind of a one-fourth of a shloka line. So what do we understand by it? Obviously, in 2000 as a final year BMS, no, I was just thinking, "Arey yaar, ye ho raha hai, ye hoga, ya nahi hoga." No, all kind of confusions as a final year student you may have, and we never knew the practical applications of it. We did not see one case. When I say these words, I don't regret the fact, but then it's a bit unfortunate that we did not get a chance to learn it in the academy, because it was never in the academy. It was, we learned from other sources. So this is why I want to make it very easy, because many of you may be final year students, and maybe some of you interns, but you have to believe that it is true and that it is possible. It is definitely something that is happening, and that's why I use the word the. And you see very clearly the tatrabhata pitta kapha dushta shonitam yatha sankyam, and the shringa is coming, and this one word or this three-fourth of the line of a shloka, we leave just jaluka, we just keep that away, and we just have to make sure that we are in a position to understand what is the clinical utility or relevance of this topic. This is what actually matters to us. Without this, it is fairly useless to study these shlokas. This is what I would say. It is absolutely waste of human effort and human memory and workforce if we keep studying these shlokas and we don't realize the practical details of it with intricacies. This is my thought for it. So again, this just to keep the audience engaged about this process. I'm just showing you how you can use it. If you log in to the website ID that you have seen, agnivesh.info, if you see that, I have mentioned it very clearly, how you can access this website. And the same you will find with Sringam also. You have the review of the literature on the left-hand side corner. You have the entire process of the classes that have been taken already. I mean, what I mean is that even if this session I had not been here, you could still profit from the website to a fair extent, if not fully. And then you see how a case sheet should be. And then you see learning material. So everything is there. Whatever you may need, everything is there. Everything. So I'm just giving a feel that even if it's something that's not fully covered here, you may still have a chance to get into this website and make the best of it. I'm just keeping it for a minute. I know the full quorum comes by 8:20. I understand that. So I'm just engaging you. And then I think by the time the full quorum is there, we will get into the process. So I think I'll close this video. 1 second. Zoom share. I think that's fine. Anyway, starting here with my teacher. Somewhere in 2012, somewhere in the Tripunatara, there is a town, Tripunatara in Kerala, near Ernakulam, college of Ayurveda, government college. One Dr. Ganesh Malwade was pursuing his studies in Shalya Tantra post-graduation. He's from Maharashtra. I have mentioned his name with his phone number in case somebody wants to thank him or have some advice from him. He's my teacher. He's my teacher. I'm very grateful to him. And so are my friends too. Just by chance, I met him and we had a fantastic understanding of that. I collected a lot of information from Kerala Ayurveda and he collected quite a lot from Maharashtra Ayurveda. And we had a very quick, gelling enough. I requested him to stay in my home and he did, he obliged. And we exchanged a lot of informations, audio recording them, etc., etc. And all of them are there in the internet, in the website anyway. Why I'm telling this first link? Well, I'm not lamenting the fact that I had to learn 12 years after crossing graduation, but I really think it could have been earlier, would have been more better for my patients. This is why I say 2012 first link. And it's a chance meeting, just by chance meeting on the staircase of Ayurveda College Tripunithara made me know about him, and he taught me this. So it's always a sense of gratefulness and thankfulness. He's the first link. Anyway, like the last days, my long-term objective today and beyond is obviously to share everything I know, and then to empower at least 75% of this audience so that they can start the process, one thing, and also what is learned is, or perhaps the relearned here. And as again, last time I would say, everything should revolve around the Vaidya. Everything. Vaidya should be the central theme. That is very, very important. But for a Vaidya to be the central theme of the society, of Ayurveda, or the entire medical process, or the medical scenario, the Vaidya has to be powerful. The strength of the Vaidya comes, of course, by knowledge. And so I would always say Shastra is somewhat equal to Shastra. This is what we are trying to get through this series. And I would have to repeat this again next week also, excuse me for that. So at least if 10 doctors in every Gram Panchayat can start it, it's easy. So let us start with something very dirty. Before we get into cleansing, we have to look at how something could be stagnant. We may call, Srotorot, we may call Malasanka, whatever we may call, something like this. You say, Behti hui nadi, अच्छा है, और that रुका हुआ दरिया गंदा है, whatever you may call, the flowing river is always great. And this applies to the fluids in the body too, including blood. And this is why I really wanted to seek your attention to the simple fact that we are trying to remove something that is stagnant. And stagnation always causes a scenario of pain, and that we don't want. So a common I always have the habit of verifying if I hope you hear my sound. No, if somebody could confirm.
Yes.
Yeah, you're audible. You're audible. No
it
problem.
is just to verify. So what to do when I would repeat this question after another 15 minutes for my assurance. Right? So what to do? Ruksha and Snigdha not working. Ushna and Shita not working. What to do then? Because these are the parameters. So obviously we go for the bloodletting in whichever form we do. And this situation doesn't really help the physician. And that's what we want to counter it. Because there are conditions where the patient gets some relief, but the relief is not really sustained. It's not greatly being in the system for a longer time. And then the patient doesn't leave you. At the same time, the patient feels terribly frustrated that we have hit the plateau and we're not progressing further. And that we don't want to happen to anyone. So this is where the role of bloodletting comes. So anyway, what my point of communicating to you through this slide is, agreed, Vada and all those things, Vata and Srinka are mentioned in the two slokas that you saw. But if a commoner asks you, a layman or a non-medico, or even a medico for that matter from another system, dear doctor of Ayurveda, please tell me, what does that Vata and what does the Sringa mean in reality? Obviously, there are some identifiable parameters, or there are some identifiable clinical conditions that need to be taken into consideration. This is very, very, very important. Because unless we have a situation where we can prove to the modern society that, boss, that's why I call my patient sometimes, boss, this is the specific situation where I would employ the technique of Sringam. This is the idea. So that is why I am using the word modern day. That is what is more identifiable. In that comes, there are many people with severe chronic tenderness, very tender, very tender. And of course, it can be a chronic injury. There are situations where there's a localized discoloration after an injury, possible for a long time. People who have what is called chadava, or a post-cellulitis induration, which are very difficult to go off, or lack of sensation after injury. These are kind of very generalized indications. And the situations like bursitis very common, agreed. Tendinitis very common, agreed. Of course, we may use Supanaha, effective. We use Rasotamati, courtesy Dr. C.D. Sadevan sir. Rasotamati in tendinitis, fantastic. All fantastic, no doubts on that. But God forbid if it doesn't help us, if it doesn't give the desired result. And then we have a situation of fibromyalgia, more systemic, which we find very commonly. There's a component of SHOFA in that. I put question mark. And fibromyalgia remains as a very enigmatic entity for many people by virtue of its reasons, because you don't typically find so-called lab proofs or radiological proofs, but the patient suffers to the extent we even think that if the patient is bluffing, which is not the case. So, and then we also have situations like knots. In Hindi, you say gant, like a goli, like that. And it's also found in many patients very commonly when we examine. So these are realities that cannot be denied for sure, and that we have to take care of, because we would like to start from the point of getting into the indications which we can verify. So I think this can be easily skipped to the next one. And tendinitis, all of us know, bursitis, all of this, all very clear cut. And please keep in mind that you know that the modern day indications doesn't have to be limited to what I am showing here. This is my first-hand direct experience, agreed. But then there could be more. And that is why in the website that you saw, I had mentioned something called submit work. If somebody is interested to share their experience, then it is very much possible. So here it is. We go to the next one. From a more systematic or systemic, now we go to the specific region-wise. Cervical spondylitis, the pain component is there. And periarthritis shoulder, you will get points which are very tender. Of course, we would just swap tennis elbow and golfer's elbow. All the, I mean, we are going like this. We're just coming down. Cts Carpal Tunnel, very common. The patient would typically say, I mean, these are nothing to be diagnosed. They are already there. Patient invariably comes with a diagnosis, or else we will figure it out anyway. Carpal tunnel is one of the situations where the referred pain would be towards the shoulder, actually, and the pain invariably goes upwards towards the shoulder, going from here further. And then people say, they can't even squeeze a torta or like a taulia. The bike, they cannot run easily. And so many things. I mean, we are not talking the diagnosis here. Then there are many people with localized tenderness, low back ache, with severe tenderness. Doesn't go do whatever. Do whatever. You have done the Upanahas, you have done the Kashayams, you have done the Anulomanas, you have done the Matra Vastis, you have done the bigger Vastis. And when you put the time, money, and effort in all that, and you still don't find the result, it is definitely disappointing to the physician as much it is to the patient or the health seeker. So this is why I'm coming to that point that there are situations where we get fed up. All the medications exhausted. Okay, you can change to Saptasaram for a low back ache. You can go to Rasna Saptakam, agreed. Then you may go to Sahajarati Kashayam, agreed. Then you use Hinkvajate and Lomana aspect. And then you will think of the degeneration using Dharmandra 101 Avarti as drops. And then you'll go for the localized Snehana in some form if the Rukshna aspect is not helping. Then the Vasti is being done and what not is done. Kiddy of different nature are done. And the kiddy is costing 300, 400 rupees per session in a day, localized. So, I mean, amount put, the money involved, the investment made by the patient and everything, we are still not in a position to get into what is called as an effective impact. And this is very frustrating for the patient always, as much it is for us. And then plantar fasciitis, Madambu Vedana, whatever we may call it. And plenty of people have it. And they will typically say, get up from the bed, chatti nadakku. They say that, I am kind of walking, limping for the first few minutes, few seconds at least, but definitely mostly minutes. And after a while, I feel better. That typically happens with plantar fasciitis, as much it happens in calcaneus spur too. In calcaneus spur, you will have the X-ray evidence too. So it's all very typical AMA-like features. And that is not comfortable because the initial hours of the day are the ones that are bothering it. This is one thing. This we don't want to happen. But before, now we have just finished the indications, and I'll come to the video. Definitely, I'll come to the video of the procedure. I thought maybe by 8:30 we should get into the video, because all those who wish to come to the session, they will be here by 8:30 for sure. So the pre-procedure involves blood routine to be safe, because whenever you have a procedure which is parasurgical in nature, it is not really funny for the person to endure, because it involves something that is not very traditionally done, not very conventional. And first of all, the Ayurvedic community itself is not doing it regularly. At the same time, the allopaths are not really always endorsing it. Obviously, we know hijama and the wet cupping, etc., is happening in many places. That's also happening. So, what I mean is that in this process, we have a situation where we need to convince the patient, and that is not always easy. Agreed. Government Ayurveda college or government institutions, people may agree more easily, because if they want, they can do it. But in private sector, it's not very easy. So we need to make sure that the patient feels convinced, and also the patient feels that yes, I'm being guided well through all the videos and all the processes, and that there is a systematic approach of the Vaidya, I mean the physician, doing it very clearly. So that is why I say the pre-procedure is also very important, and that is precisely why not only CTBT and group of things. I mean, it's not a huge, copious volume of blood going out, but then it's just nice to have this simple blood routine also. And the fasting blood sugar, because you're getting incisions, so small cuts, it's an indication basically. And then of course the awareness video, whatever you need, it's always there. It's always there. And now we get into, I mean, small short break. Already, I've seen that the number of people who have got into the website after this started has increased, and it's all there, all the information. As I mentioned, no, if I spent 7 lakh rupees in the last 8 years' time, I really wish that at least 10,000 doctors profit from this. It's only 6,000 something now, and then if more patients can be profited, it will be fantastic. This is my idea. So I put something like, you see Dr. CB Sajeev sir, and I would really like to hold this screen for at least 10 to 15 seconds, at least, for two reasons. One, you should know that he is far, 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 far experienced than I am. I'm very thankful for his guidance and his mentorship. And I put something called 3B, because when we were discussing what to present, so I said, sir, my presentation is ready. It's there for easily an hour. I can be involved with the audience. And then I said, sir, what extra things can we offer, so that it's the value of the time they spend for this presentation. And he and me were discussing so many things. We ended up discussing, even if you're familiar with the topic, both of us, more than an hour. Then I said, sir, I think I should make a part B of this. So some very special experiences, they will come in the coming days. It will happen. We are planning that. So that is to be kept later for sure. And you have his number there in case somebody wants to interact with him. For me, he is a super specialist of Anushastra in Kerala, for my feeling. And I'm very sure about what I say. So I just put that coming soon, next session or even beyond that. We'll figure it out. We'll easily plan that. This is not the original syllabus that I had volunteered to AMI leadership, but I think we'll figure it out. Again, another video. So assuming some of our friends, now it is kind of a full quorum, assuming. So I'll just play it across. This is how you'll get into the website, Agnivesh Info. You'll get into the Sringam. I'm just showing it for those who have joined now only. It's the same thing that you have seen. I just took the front side of the website. So then everything is there. And it's the cases. And there's something called doctor posters. And that's what was shared in the very first video that you saw. So I'll just off that, because now it is not needed. And I think that should be fine. So here we go. The reason of all these, let me see, somebody has mentioned a chat. I don't know what it is, but I hope if something I should know, somebody would, Dr. Vishwanath, you would correct me, I hope, if there is something I should know.
Nothing.
I'm
There's
not.
no issue. You're audible. There's nothing in the chat. There's just
Okay,
a
okay. Yeah, okay,
message
no
call
problem.
yes.
Yeah, okay, that's fine. That's fine. So the reason of all this is our basic concept: valuing the time, money, and faith. People invest in our services. Very, very important. The reason is simple. You know, for me, coming from a middle class family, always prefer a situation where a coolie class person earning about 700 or 800 rupees, if we can give relief to his health life at a cost one tenth of what is normally his salary, if I may use that word, or income or earning, then it is nice. So I know prescriptions would vary. If you use gold, cost is more. And if you use even kashayam, it's like one bottle would cost 120 rupees these days and times easily. So I understand all that challenge. But if we can make it affordable to the public, the popularity is more, the number of people availing Ayurveda would be more. That's why, for me, money comes more important in that context of popularity. Of course, faith has to come by result. And the more we save the time of people, we get more popular. And this message I really wish is conveyed to the college academy young students. This is what I would imagine. So here it is, like coming to something, what is a reality? You see some coolie people working, very hard workers. And for me, there are three agendas of this view. The first thing is that we need to deal with people whose income is not very high. First thing. And we need to deal effectively. Secondly, a coolie doesn't have the privilege, rest, etc. It doesn't happen, boss. A coolie class person has to go to work next day, even if he has an injury. I mean, there's no other option. Ghar ka chula jalna hai, you call the breadwinner of the family. So we need to have that kind of competitiveness. This is my point, the third one. The competitiveness where somebody very busy, as a coolie is, or somebody who can't miss, how we can make him fit for the work next day. This is the idea for this slide. So coolie class people, they may earn less, understand, but equal to or maybe more pressure are the athletes or the sports people that I have put here. And this idea came to me from Dr. C.B. Sajeev sir, because he has been very actively involved in the sports Ayurveda of Kerala. And he has more than 100 kind of injuries being very well treated by him. And he was telling me that, Sreejith, we need to get these, whenever these people are getting injured, the modern medicine, ortho, etc., they would typically say, you need this much of rest and XYZ. And 2 to 3 weeks rest. But what he does is he employs this parasurgical of Sringam and such, and make sure that using some kinesiology techniques and such taping, kinesiology and such, the person is in the field the very next day. So what happens is, in the process, we have a very clear, effective method wherein the so-called high-end, if I may use the economic parameter of high-end, professionals of sports getting the benefit, and the so-called at the lower end, I mean, totally on economic parameter, nothing personal, nothing else. The so-called lower end people also need to get into the work very next day. And we have to break the traditional or the way we were trained in the academy about Ayurveda rest വേണം, ഇനിയിപ്പോൾ 2-3 ആഴ്ച വീട്ടിൽ ഇരിക്കണം, rest. I mean, it's not friendly enough. It may be shastrokta, it may be necessary, I understand all that, but it's not friendly enough. We definitely want a situation where we have what is described as a very clear-cut competitive edge. This is my point from these two slides, and it is possible. This is why I wanted to convey to you here. And then some current realities. This was already discussed before. I have no other option but to share here again. And know how much can you earn by your prescription making. the percentage of margin from agency, how much can you make. So you have the competition from the genuine doctors and genuine professionals. Or you have from the quacks also. Doesn't help. And why I say the word quacks, because there are many people who are not registered, and then but they're still popular, and they are your competition. It's a matter of livelihood, and we all would struggle 5 to 8 to 10 years in our career. So we need the money keeping on coming to us and such. So this is something that we would make sure is not happening to our youngsters if they get into the parasurgicals. And you saw that point. It was Dr. Sadat who had, my senior Sadat. Sadat was telling me, Sreejith, we really need to help our youngsters and get them into a very respectful and decent and appreciable level of financial gains. And that is possible quite a lot. And that keeps the what we call the enthusiasm quite high and consistent. Again, this has been shared before. The parasurgicals, they definitely cater to conditions which are not satisfactorily managed by allopathy, as you see very clearly. And this is where we have to use, like when it comes to liver ailments, we all have from very childhood this liver Ayurveda, jaundice Ayurveda. I mean, for surgical situations of oncology, jaundice of obstructive nature, we may not be really always effective. Agreed. But hemolytic and such, which is not an oncology scenario, we have a better edge. So that way, the public psych has to be formatted in such a manner that, yes, these are the list of conditions where we Ayurvedic people are doing it fantastic. This is what we have to make our generation next, or our so-called juniors by age doctors, to feel confident about. Obviously, the cost is less. Instead of wasting lots of money on kiri and kiri after kiri, if we can decrease the cost by 50%, why not? And it happens. It definitely happens. And if we can make sure that there is a quick relief and the patient's confidence is retained, and also the patient is retained, is also very important to ensure that you are able to serve them better and you're able to prosper. As much they prosper in their health, you need to prosper with your wealth also. Their health, our wealth. So we say Jai Mangal. There's something called Jai Mangal Ras. आपका जय जय हो और रोगी का मंगल भी हो. That's I take this from Dr. Tapan Kumar Vaidya sir from Ahmedabad. So again, as I had mentioned very clearly, we need to match the expectation of the patient very clearly. T20s I will always put equal to parasurgical. The test match I will always put equal to panchakarma. We have to be equipped and efficient in both these versions of the engagement we have with the patient. Very, very important. Agreed, some patients may say Ayurveda may take time, XYZ. I understand that. Some degenerative conditions we are using, I understand that. All agreed, definitely agreed. But it is also very, very important to make sure that you have a quick relief given to the patient so that they can listen and feel the confidence to listen to you further. So again, if you could see now we have about 150 of our friends in this. Now starts the real intense session. So I have mentioned very conveniently the minimum cost involved is 20 minimum. And why I say so, I'll come to that. Of course, you need a spirit or even a small Dettol is fine. A local vaporizer is nice, not always necessary. We need a 12 mm surgical blade to get the incision. But we also can manage with number 18 needle, veterinary needle, or even number 24, which is much more easier and comfortable for the patient. And I put that both of them in star because I did not used to use it before till Dr. Sajeev sir advised. So that's why I'm using the word even barber shop blade. So, dear friends, it's very important that whenever we try to I won't say teach, that's not my intention here to say so, but whenever we try to share information to our fellow doctors, we must make it look very simple. Our heart is simple, so why can't our words and our deeds be simple? So that even the patient feels that it is something that can be easily undergone or undertaken for their health. So I will use the word razor blade. It may not sound very technically polite or technically amusing. Razor blade, no? Are we talking of a barber in the roadside in the Indian, in the medieval age India or pre-independent India doing it? But I'll come to that point with the razor blade. Sometimes it is more better than the surgical blade. So, but it may not look nice. The patient may not really like the idea that is it a roadside vaidya or a barber like doing that, but we'll have a solution for that. So I am putting two numbers of them simply because it is a situation of uh, if one blade doesn't work, it breaks off. Let us have the standby. And then I put the 20 and 10 ml syringe. I put the hijama cup also, which is preferred. And then hijama cup, of course, looks nice, obviously. But then now you had the class Saturday evening, night. Tomorrow, 10 o'clock in the morning, somebody has indication for Sringa. Of course, Amazon online would take time. The medical shops would open Monday only. What can you do? You have to give relief, no? You have to give relief. Obviously, most of the medical stores are open enough to get a syringe, 10 or 20 ml. So that is why I'm trying to make it very friendly and simple. And it is that way. Obviously, it's nice to have a cotton. You need it anyways, to scoop off or remove the blood clot. And then kidney tray is nice, but you can make it a bit ugly by not using kidney tray. You can put in a plain paper, like the dirty newspaper that you saw at the last presentation. So for this reason, I would say it is very important that we make it look very easy for our youngsters. And if you really take the razor blade 2-3 rupees, obviously you take this syringe 10 rupees, and the amount of cotton you may use is like not even 5 to 10 rupees. So it is something that is so cost effective material wise, and that is very, very important. And then you see that Murvanna is what I was using majority, and I was lucky, I would say, and that none of my patients had a situation of blisters or infections or something like a pustule and such kind of nasty and difficult situation. I put betadine as a star there, asterisk mark, because it is taught by Dr. Sajeev sir, who said that for him, more than our Katarvada, that is Kumari, pulp, uh, even more than the Murvanna itself, he found the betadine to be the safest. So, I mean, that's experience, and let us just accept it. And then, of course, you need a paper plaster to just cover with the cotton and cover it up. And why Drakshadi Kashayam and Dhanvantram Gudega? Many people, they may have a syncope looking at the blood. They may feel tired. And if not the process by itself, there is psychological fact of seeing the video and looking at it, they may feel tired. So it's give a shot before the process. Dhanvantram Gudega for two group of people. One is obviously the patient, so that they feel any kind of difficulties, general difficulties, Dhanvantram Gudega to take care of it. And it is okay to give to the bystander who is witnessing the process, because the bystander faints down many a times. Sometimes the interns faint down many a times. It happens. So let that be there as a prophylaxis. Balayishtam Partharishtam is always nice, the cardiac health. And face mask, very, very, very important. It can be simple kerchief, fine, a simple towel, fine, to cover the patient's eyes. This is a bit challenging. Many of the people, they say that I'm telling you practically challenging things that you don't have to be embarrassed about when you start doing it, or if you're already doing it. Because the patient, they will say, I have the right to see what is happening to me, which is true and which is correct. We respect that. At the same time, we also know that too much of showing the entire process may make them syncope. So not really funny. So for that reason, you can say the reason very effectively and say, look, boss, when it is a male, I say, if a patient is a male patient making some kind of drama, even after our best explanations, I say, boss. But if it's a lady, I will say, darling. They listen better. So they need to be very clearly given the confidence and the safety. I'm doing a safe procedure. Don't worry. You may scream. I understand that. Because I have seen many of my patients, when the Sringa is done, they see the video, everything agreed. They take a small towel and they bite it. This kind of, the first prick you make, it's all this howling. And then it puts a negative impact for the bystander who is looking at it. It feels like a torture chamber. And that we don't want to happen. And then the face mask to cover the patient's eyes. Not really, no, a very convenient thing, I understand. But then this is no other option. And what other procedures that is nice to be done? It's nice to tell them, no, this is a meeting point, this time and this date, bang, that's it. It's a major process. It's something very serious to be done. So no, the patient feels like it's something happening. We just come when you want. I'm there in my clinic. It trivializes and makes things feel really simple and not so serious. And that we don't want to happen. That is why very important that you should make them feel like it's an event. It's an event that is so important for you and for me too. And that's why the intimation of time and date very important. Obviously, checking the blood pressure is always good. And the localized abhyanga just makes it much more suppler feeling. And the Svedana makes the vasodilatation much more easier. But I tell you very frankly, I've done for many, many patients without following this abhyanga and Svedana. It is still okay. It is still okay, not necessarily all the time. But the person should also feel a process is happening. That's very important. The video of the procedure is coming soon. And why I'm putting the word coming soon, I know you are eager for that. A polite blindfold. Very, very, very important. Very important. A polite blindfold. So this is a special advice from Dr. C.B. Sajeev sir. Now the question is, we have prepared the patient. We know the indications very clear, point blank. We know the materials required. We know the preparation, psychological and physical preparation for the patient. We have the blade is ready, or the surgical blade is ready, or the razor blade is ready. The question is, how much is the pain a patient should feel from the process? So when I was doing in the initial days and times, the Sringa was one of the most horrible, politically horrible process for many, many people. Because the patient would scream like hell. And then in the dining hall where all the patients gather and socialize, they would be telling very bad things about it, not the impact, but the experience of the process. So this really puts off future candidates of Sringa who are into the waiting list of getting into the process. This is a very politically tricky situation. And that's why it's very important that the patient gets an impression that, okay, this is what I'm getting into. So that is why you have to tell very clearly, look, what I do for you would be something like an ant biting for a chronic pain that you are carrying along with you for a long time. Is that okay with you? So when they say, yes, okay, boss, let us get into action. So this is, and you really have to make them feel like the pain of an ant when you do the incision, as small it is, because it's not really fun to be pricked time and again. Supposing if this is area which is not 1, 2, 3, 4, 5, 6, like no, you're keeping on pricking. Sira Veda, one shot. Just give one prick, the blood comes, agreed, fine. And then when it comes to Agni Karma, one prick, done, clear, agreed. But when it comes to a situation of what we call as the Sringa's repeated prickings, the repeated is a word, it's not fun for anyone. And you yourself don't really feel great if it is not happening the way you want it. I mean, which means a very peaceful manner. This is why this indication is very important. Again, then the next thing is what we should do is this, and how a patient should feel was conveyed before. I use the word touch ko, because you just need that rectum podiva. Taki barik say, it just gets touch. This is the simple idea out of it. And again, if the blade is not accepted, because you have to tell to the patient, look, I'm using this. Is that okay with you? And they may say, look, I don't like the this kind of barber razor blade. They may also say that I'm not comfortable with surgical blade. Then we say, okay, boss, then we have another option. But we still have to prick the blood anyway out of your body. So these are the different options I put for the needles, which is also fine. And now the eliciting the trigger point. So this brings us to the point, something which is not usually taught in the college academy. Even my postgraduate friends in Shalya Tantra had no clue about trigger point when they were studying. So we're talking something about 2005. And I don't know if this is being taught now in the academy now. I don't know. But at that point, it was not being taught. That's for sure. So that's why I use the word trigger point. I'll have a simple PowerPoint on that one shot. So agreed. And so all that we had, that Vata and Shrinka, these are only two keywords we had. And this Vata got elaborated by these modern day indications. It's a more of a Vata Kapha scenario actually. And then we are reaching the point to elicit. How to elicit and how to determine, okay, boss, this is the point I'm going to prick you. That eliciting is the most important thing. Procedure is easy, piece of cake, easily doable. But eliciting is the most important point. And this is what we have to get into. So that comes here, a trigger point. Why I say this word trigger point? You may have a pain somewhere, but the origin of that would be somewhere. I would request you to look at the right-hand side where you see the referred pain, which means that a trigger point in one muscle can create pain in another area. So you have pain somewhere else, and then the reason is somewhere else. And that you saw with the two tennis balls kind of in white color and two arrows indicating it. Trigger points are very, very painful areas. As I said before, like a gant in Hindi, like a knot, you say, like a urund, gundu bole in Malayalam, gundu urund irikina bole. And painful when pressed on and cause shortening of the muscle fiber typically. So this is to be learned. So now we get into the procedure video, and let me get into the, I have to use a screen for that. I think I should escape for that matter. I'll escape. Or rather, I'll bring it down. And I'll get to that something called procedure video. Something called 3 Sringam, and I'll take one girl from Hyderabad. On 16 May it was done. So now we are getting into Dr. Vijayanath. I'll putting the sound on in this video, and if you don't get it, please let me know.
Okay,
because sound is not audible to you or the audience.
Okay.
Because it is nice to hear the sound, and no, this is the most important part. I don't know, should I make it big or how does it happen?
ഈ ലെവലില് പിന്നെ ഇവിടെ ഉണ്ടാകുന്ന ഇവിടെയാണോ? എത്ര നാളെ ഇപ്പൊ ഇവിടെ വന്നിട്ട്? എത്ര നാളെ തുടങ്ങിയിട്ടത്? 2 വർഷമേ ഉള്ളോ? 2-3 വർഷം. എങ്ങനെ തുടങ്ങിയത്?
There is no video, just the sound. No video, just the sound.
No video?
No video.
Okay, let me see that. Because we have made the trial run. Let me put it this way. Maybe now. Because we had made the trial in the evening again. I hope it works. It did. Maybe now it works. Let us see. Now is the video there?
No.
Even now not?
Just the audio.
That's strange enough, because me and Dr. Ajmal had our share of no. I see it here. but I don't know if it has to be shared with you or how does it happen? No?
Dr. Ajmal.
Because it is in my desktop. One second. Let me see. Still, it's not there.
No. Just the sound.
Yeah, Dr. Ajmal, how did we manage it last time then?
I think a suggestion has come. Close the presentation and start the video. So, but you have to share
Okay.
it, no, sir.
Yeah. We'll do that. I mean, because it was working. So I think I should close this. Am I doing the right thing? Stop share. No, this is what I should do. Is it like that?
Yes.
Yeah.
Let me stop share. If that makes it easy. And now I think it should favor us, hopefully. Reduce it. Maybe we have a luck this time, God willing. Is it still the same situation?
സ്റ്റീം അടിച്ചിട്ട് ചോളം ഇവിടെയോ ഈ ലെവലില് പിന്നെ എവിടെ ഉണ്ടാവുന്നത് ഇവിടെ
Let me hold.
ഇവിടെയാണോ
Did anyone
Just the sound. No, just the sound only.
That is strange. Anyone has any other suggestion? Or else we'll have to use the...
See, they are asking you to close your PPT
Totally.
and start the video and start screen sharing.
What we do
That's
is we will remove all the PPT, whatever has, whatever is happening. One second, I will cancel that. Let me remove all the PPT there. We can always come back to that again. I think, does it mean to save? I don't think it is save here. You still see the PPT? Is that the case there? We need to reduce it, no? That's what I think, because that's there. It's like hidden there actually.
I think just start the video and screen sharing. Dr. Ajmal, can you please intervene? Dr. Ajmal.
No, I see on my, but is this the one to be shared on the screen? Is that the meaning?
Okay, you can start sharing screen.
One second. Save. I'll save it like that. Okay. Does it mean? No. It's not something to do with the airdrop message. No. That's not the case. That was the important thing. So I did not want to miss that actually. Maybe now I've just deleted that so that it's easy. And does it happen now? One second.
എത്ര നാളായി ഇപ്പൊ ഇവിടെ വന്നിട്ട്
You have to start share.
തുടങ്ങിയിട്ടത് 2 വർഷമേ ഉള്ളോ 2-3 വർഷം എങ്ങനെ തുടങ്ങിയത് ഇവിടെ തെന്നലുണ്ട്
Doctor, I'm not getting it through. I don't know why.
You can just share after starting the video.
No, that's what I'm looking at, but I am in the process. One second. I'm online, that I know. I'm with the audience, that I know. But how does that go further? It's a totally unexpected jinx. It's fine. No. I'm not getting it there, doctor.
See, can you just restart the screen sharing and then start the video?
Yes, I'm still online. So you want me to close it, no? That's what you meant. Closed.
Restart the screen sharing and then start the video. That is a suggestion that has come in the chat box.
So
Dr. Ajmal, can you
the
please
challenge
intervene?
I face here is that I am not getting to that screen of the screen share. This is my problem. I'm getting my PowerPoint only, but I'm not getting to that specific, no, the specific screen. I know I'm still in the Zoom, that I know.
Yes, yes.
I'm very much there. I have not come out of it. So why does that doesn't come? That because that icon, no, which shows the number of participants and the what we describe as, you know, the green icon, but that I don't find it now here. But I can still listen to all of you.
They just ask him one suggestion that has come is just minimize the video and then start the screen sharing.
Yeah, it is minimized. For me, it is minimized.
And have you start? Can you just restart that screen sharing option which is with you?
Because I'm using the icon that is already here. Not getting through.
But last time you did it.
Yeah. I mean, it happened even more than an hour and a half ago with Dr. Ajmal. That was happening perfectly okay.
Or you just mail? Can you just mail it to the host, Dr. Ajmal? He will play that. I think
Video.
so. Yeah, it's very
What,
huge.
what I will
What
do
is
is,
size?
meantime, we will come to that specific. Definitely, I will take the help of one of my staff in case, so that we will keep going ahead with the process, saving the time of everyone. And I think we will easily get that through because this has already been tested and done before. And I will get that. And for that, let me mute myself for a moment. Because what you say as a screen, I'm not getting. Ashish, no contact him. Urgent. I'll get my staff because we three had done it. We'll keep on going nevertheless. And
Okay.
I promise that we'll get that through. No problem at all.
Okay. Continue. Can go on, sir.
Because so what happens is once you make the prick, you have to ensure that you're holding to that area. And so do you see this now? Is this happening? I mean, is it still on the screen? Do you see a PowerPoint now?
No, sir, no.
No. We are not seeing the PowerPoint.
Yeah, okay. So there's something very strange in that case happening. Because I am not out of the, no, what to say? I'm not out of the screen. You all hear me.
Yeah, we can also see you.
Yeah, absolutely. Thankfully, it's a familiar audience, or I should be sweating by this time. Let me see. So anyway, I'll keep continuing till that point. Is that whenever we have the prick done, that is the most troubling point for everyone, because that acceptance is very difficult. The patient may say, come on, stop it. Nothing, I don't want to go ahead more. Absolutely not. The patient can even say that I have relief already. That's another way of excuse to back off. So this is to be handled very clearly, because once the release happens of the blood, majority feel a good relief, but there's a small minority that doesn't get the relief, and that brings a very, very difficult situation for the process to continue, because you're given the prick, the blood is coming, patient says, come on, I don't want to go forward much, and that is something very tricky situation to deal with. And once this process is over, the blood is coming up, and we'll get a video anyway. The blood is coming up and it's stagnant. Once it is stagnant, at that point you have something that says to you, come on, that's finished. Sometimes more than what you have expected, blood comes up. At that point you don't know what to handle because you have to take it out anyway. So this is very, very important that we manage. Ashish, one on the corporate. I hope this gentleman saves the day for us. Ashish, ento challenger ya. On the screen on the corporate. So the challenge we face now, Dr. Vijaynath, can you please help my caretaker to?
Yeah. Dr. Ajmal, can you please intervene?
Ashish എന്താ അറിയാം?
You have much technical know-how than me.
No
Dr.
problem.
Ajmal.
കാരണം നമ്മൾ we are very late, very clearly. എനിക്കാണ് അത് ടോപ്പ് കിട്ടുന്നേ ഇല്ല. ഞാൻ മീറ്റിംഗിലുണ്ട് ഇപ്പോഴും. നോർമലി ഗ്രീൻ വരുമല്ലോ മേളില്. ദാറ്റ് ഈസ് നോട്ട് ഹാപ്പനിങ്. അതാണ് ബാക്ക് ടു മീറ്റിംഗ് ഇസ് ദർ. ബാക്ക് ടു മീറ്റിംഗ് ആണ്. നോക്കട്ടെ. പക്ഷെ നമുക്ക് വീഡിയോ വേണേ. ഒരു സെക്കൻഡ് ഇത് സോർട്ട് ഔട്ട് ചെയ്തിട്ടെ. ഇതിപ്പോ ഷെയർ ചെയ്തല്ലേ? ഷെയർ. അപ്പം വാട്ട് ആർ ബി ഷെയറിങ്? അങ്ങനെയാണ്. അല്ല, ഷെയറിങ് സ്ക്രീൻ ഓക്കെ ആണ്. നമുക്ക് വേണ്ടത് ഈ വീഡിയോ വരണം. നമ്മൾ നേരത്തെ ഡോക്ടർ അജ്മലുമായിട്ട് കോർഡിനേറ്റ് ചെയ്തായിരുന്നല്ലോ. അതല്ല. ലെറ്റ് us see. അത് 16 May അതന്നെ ഡെഫിനറ്റ്ലി. എലിസിറ്റിംഗ് ട്രിഗർ പോയിന്റ്. അതായത് എനിക്ക് കേൾക്കാം, ഓഡിയോ അവർക്കും കേൾക്കാം, പക്ഷെ വീഡിയോ കേൾക്കാൻ വയ്യ. കാണാൻ വയ്യ. വെരിഫൈ ചെയ്യാം. നോക്കാം.
കാണാം. You can see that. Yeah, sound is also.
ഇവിടെയാണോ? എത്ര നാളെ ഇവിടെ വന്നിട്ട്?
Yeah.
എത്ര നാളെ തുടങ്ങിയത്? 2 വർഷമേ ഉള്ളോ? 2-3 വർഷം. എങ്ങനെ തുടങ്ങിയത്? ഇവിടെ തെന്നലുണ്ട്. ഡോക്ടറിന്റെ
This is eliciting the trigger point. So Ashish, escape അടിക്കണമായിരിക്കും most likely. അത് നമ്മൾ നോക്കാം. 5 മിനിറ്റ് നിങ്ങളെ ഫ്രീ ആക്കാം.
ഇവിടെ തോന്നുന്നുണ്ടോ? സ്കിഡി ഫീലിംഗ്. അതാണ് എന്റെ സ്പോട്ട്. അപ്പൊ നമുക്ക് ഒരു ഇയർ മാർക്കും ചെയ്താലേ.
So the reason I am communicating to you is that this is the most crucial point by all means. Once you have the point very clear, everything is easy.
ഇല്ല. ഇപ്പോഴോ? ഇവിടാണോ? അല്ലേ? ഇവിടെ തെന്നുന്നെ. ഇവിടാണോ കൂടുതൽ വേദന? ഇപ്പുറത്തേക്കായും സൈഡിനേക്കായും? അപ്പൊ ഇവിടെ റൗണ്ട് ആക്കാം നമുക്ക്.
Round means you'll make a
definite
marking. So now what we have done is eliciting the trigger point, where to do, but let us prepare the procedure. And here we get into the, I hope it's seen now, unlike last time.
Actually.
No, it's not in this one.
നമ്മൾ ഈ സിറിഞ്ചിനെ ഈ സൈഡും കട്ട് ചെയ്തു. ആക്ച്വലി റിവേഴ്സ് ആയിരുന്നല്ലോ.
You are able to see it and hear also.
ഓപ്പോസിറ്റ് ആക്കിയെന്നേ ഉള്ളൂ. അത് നമ്മൾ ഈ സിറിഞ്ചിനെ ഈ സൈഡും കട്ട് ചെയ്തു. ആക്ച്വലി ഇത് റിവേഴ്സ് ആയിരുന്നു. ഇങ്ങനെ ആകുമ്പോൾ ഇത് ആകുമ്പോഴത്തേക്ക് ഇവിടെ ആയിരുന്നു. നോർമലി ഇതാണ് കട്ട് ചെയ്യുന്നത്.
Supposing somebody has to do the
അപ്പം
tomorrow.
ഇത് ഇങ്ങനെ ആകുന്നുണ്ടോ മാഡം? ഇതാകുമ്പോഴത്തേക്ക് തൊടാൻ നോക്കും. നോർമലി ഇതാണ് കട്ട് ചെയ്യുന്നെങ്കിൽ ഈ പിസ്റ്റൺ ഇവിടെ ആയിരുന്നു. പക്ഷെ ഇത് ഈ സ്മൂത്ത്നെസ്സിന് വേണ്ടിയാണ് ഈ സെക്ഷൻ. ഈ ഇതാകുമ്പോ നല്ല സ്മൂത്ത് ആയിട്ട് നിൽക്കും. ഇത് ഈ സ്മൂത്ത്നെസ്സിന് വേണ്ടിയാണ്.
Supposing you don't have a hijama set immediately for doing it tomorrow, God forbid, and then you need that simple syringe prepared.
കട്ട് ചെയ്യുന്നേ ഉള്ളൂ ആക്ച്വലി.
The factory
നമ്മൾ ഈ സിറിഞ്ചിനെ ഈ സൈഡും കട്ട് ചെയ്തു. ആക്ച്വലി റിവേഴ്സ് ആയിരുന്നല്ലോ.
is the one in touch with the body of the person.
ഓപ്പോസിറ്റ് ആക്കിയെന്നേ ഉള്ളൂ സിറിഞ്ചിന്റെ.
And you cut the other side for that piston effect.
സ്മൂത്ത് സർഫേസ് ഇങ്ങനെ ആകുമ്പോ ഇതാകുമ്പോഴത്തേക്ക് നോർമലി ഇതാണ് കട്ട് ചെയ്യുന്നെങ്കിൽ പിസ്റ്റൺ ഇവിടെ ആയിരുന്നു. അപ്പം
obviously hijama looks the set looks better.
ഇപ്പൊ നമ്മൾ ഇതുകൊണ്ട് ഇങ്ങനെ ചെയ്ത് ആക്ച്വലി നമ്മൾ ഇങ്ങനെ സർഫേസ് മാർക്കിംഗ് ആക്കി എടുത്താൽ
the mark surface.
ഡോക്ടർ ഇങ്ങോട്ട് വരാം. പിടിച്ചോ ഡോക്ടർ, ഇങ്ങോട്ട് വന്നു. അതെ, അങ്ങനെ പിടിച്ചാൽ മതി. കാരണം നമ്മൾ ഈ സർഫേസ് മാർക്കിങ്ങില് ഇങ്ങനെ ചെയ്യുമ്പോഴേ ഇപ്പം തന്നെ കൊച്ചിനെ വേദനിക്കുക.
You can hear the child, the girl who's suffering for more than 2 years
ഈ ഒരു എഫക്റ്റ് നിൽക്കണം.
with a low back ache. I'll come to the history. Let us get the
നമ്മൾ
procedure done.
ബ്ലഡ് ഇത് കൊത്തിയ ശേഷം അതെ ബ്ലഡ് ഇങ്ങനെ കൊത്തിയ ശേഷം നമ്മളിങ്ങനെ അവരങ്ങ് പിടിച്ചോണ്ടിരിക്കുക. അപ്പൊ ഇങ്ങനെ പിന്നെ അവരിങ്ങനെ പതുക്കെ പതുക്കെ ഇങ്ങനെ ലിഫ്റ്റ് ചെയ്തുകൊണ്ടിരിക്കണം. അത് ലിഫ്റ്റ് ആയിക്കൊണ്ട് വരും. ഇച്ചിരി പെയിൻഫുൾ ആണ് പ്രൊസീജിയർ.
Comfortable.
ഇങ്ങനെ കുറ്റി പോലെ ഇങ്ങനെ കയറിക്കൊണ്ട് വരും. കണ്ട ഇങ്ങനെ ഇങ്ങനെ കയറി വന്നോണ്ടിരിക്കും. ഇങ്ങനെ ഇങ്ങനെ വന്നോണ്ടിരിക്കും. അതിപ്പോ നമ്മളങ്ങ് ഇങ്ങനെ ഇപ്പം ചെയ്യാൻ കാരണം ഈ ഏരിയയില്
and now we will be just, you see how the person is prepared. You see the area has become indurated a bit or other more of reddish. And now we look into the last portion of that. I think it's better bigger screen, then it makes more sense now.
ആരെ ബഹളം വെക്കാൻ പറഞ്ഞത്? നമുക്ക് ഇങ്ങനെ ഒന്ന് രണ്ട് സ്പോട്ട് കിട്ടിയാൽ മതി. ബഹളം വെക്കല്ലേ, അതുകൊണ്ട് ആദ്യം പറഞ്ഞത്.
Well, those who are not from Kerala, Behalam Vekele means please don't make noise. So please look at the drama that happens. It's a kind of a scene happening, all these things, no? It's not fun. So this is where the patient may even say, stop it. And this is a tricky area that we have to look after. That's why I said I was using this number 12 blade, but it was Dr. Sreejith sir who went for the choice of the barber blade, which is more better. But then it doesn't look great in terms of his glamour. Glamour is not there because it just kind of trivializes in the minds of the patients. But then, it's better that the patient is blindfolded politely.
സിസ്റ്റർ അത് ഇനി വേറെ വരാതിരിക്കാൻ വേണ്ടിയല്ലേ ചെയ്യുന്നത്. സിമ്പിൾ പിൻപ്രക്ക, വേറെ ഒന്നുമില്ല കേട്ടോ.
And you hear her sobbing, crying. Of course, satwa matters, but then
അതാണ് ഈ കൊച്ചിന് ഇത് ചതഞ്ഞ് നിൽക്കുമല്ലേ, അത് മാറ്റാൻ രക്ഷയുണ്ടോ? ഞാനാണെ വളരെ മയത്തിലാ ചെയ്യുന്നതന്നെ. അവിടുത്തെ നമ്മൾ ഒരുപാട് സ്കിൻ ഡീപ്പ്.
if this is your son or your daughter, how would you feel? Please have that empathy when you do that. Very important.
ഡോക്ടറെ വീഴുന്നുണ്ടോ? ഇത്രയും ബ്ലഡ് പൊടിഞ്ഞു. വെള്ളം വെച്ചിട്ട് കാര്യമുണ്ടോ? റെഡി. അപ്പൊ അത്രയും സ്പോട്ട് ആയല്ലോ. നമ്മള് ഒരു മിനിറ്റ് ഹോൾഡ് ചെയ്യണം ഡോക്ടറെ. നമുക്കിത് ഇങ്ങനെ വെച്ചിട്ട് ഇനി അങ്ങ് ഡോക്ടർ ഹൈറ്റിൽ വെച്ചോ, അല്ലെങ്കിൽ കാണത്തില്ല. കാണാറ് നമ്മൾ ഏരിയ കവർ ചെയ്ത് കഴിഞ്ഞു. ഇങ്ങനെ ഇപ്പോഴാണ് പെയിൻ. കണ്ടോ ബ്ലഡ് വരുന്ന കണ്ടോ?
You can see the blood like coming upward.
ലൈറ്റിന്റെ ഒരു ചെറിയ അഡ്ജസ്റ്റ്മെന്റ്. എന്റെ കൈ തന്നെ ഇപ്പൊ ലൈറ്റ് ബ്ലോക്ക് ചെയ്യുന്ന ആക്ച്വലി. കണ്ടോ ഇങ്ങനെ പിടിച്ചോണ്ട് ആരെങ്കിലും ഇരിക്കണം. അതതിന്റെ കീ. അതിനാണ് ആർക്കും സമയമില്ലാത്തത് ആക്ച്വലി. നമുക്ക്
the challenge is with the hijama, you just do it and just aram se the cup will take care of the suctions, that the sucking vacuum effect like. But when it comes to a very simpler method like this, somebody has to hold on which a bystander can do, even you can do, but it's not very convenient for the doer. But then the cost is not even 20 rupees. So we have all the options that we want.
കണ്ടോ നിങ്ങൾ ഡോക്ടർ പിടിച്ചോണേ, ഞാൻ നിങ്ങളുടെ കൈ അഡ്ജസ്റ്റ് ചെയ്തോളാം.
So I think we close that. And now the procedure is on. I think I will rush through that a bit.
സൈസ് കൂടുന്നുണ്ടോ?
Sometimes the electricity goes off. Sometimes electricity goes off in the government hospital. So what you can do is like
hand over size കൂട്ടിയിട്ടുണ്ട്. അത് കൂടും അങ്ങനെ.
I'm just rushing through it because it's the same thing that you will see. And now the mother is holding. You can see the column of blood coming up.
അറിയാം ഇരട്ടായതുകൊണ്ട് ഏറ്റവും വലിയ പാട് പ്രൊസീജിയർ അല്ല പിടിച്ചെടുത്തോണ്ടിരിക്കുന്ന ഏറ്റവും വലിയ പാട്.
We'll skip that. We will just go forward. I did not want to miss this because other things are fine, but unless we have this clarity of what we do.
ഒരു 5 ദിവസം വേണം. 5 ദിവസം കഴിഞ്ഞിട്ട് നമ്മൾ ഇതൊന്ന് ഹീൽ ചെയ്യുമ്പോഴത്തേക്ക് അവിടുത്തെ ഹൈറ്റ് കൂടുന്നില്ല ഡോക്ടറെ. പക്ഷെ എന്നാലും ഉണ്ടോ ഉണ്ട് കേട്ടോ, കൂടുന്നുണ്ട് ചെറുതായിട്ട് മേലോട്ട് വലിക്കുമ്പോഴേ.
The height, of course, I mean, it's very less that I have shown here. Why I took this example is that I'll skip to the next one.
അതുകൊണ്ടാണ് ഞാൻ അങ്ങനെ പറഞ്ഞത്. കാരണം കുട്ടി പോലെ അവിടെ ഉണ്ട്.
Small cutlet like appearance.
അത് അത്രേ ഉള്ളു സിസ്റ്ററെ.
So you have seen the trigger point elicited. You saw the preparation of the cutting the syringe and such. Procedure was on. Now you will see somebody who was suffering for such a long time. This lady was suffering for a long time. You know, all the upana has done, all the different kinds of vasti is done, dhanamla dara done, lepanas, all whatever, all kind of things done. More than 2 weeks already in our hospital. And one of my seniors, she was very magnanimous enough. One of my seniors in the government service, very magnanimous enough to say, Sreejith, no, why don't you try what you're doing with other patients and all. She just gave the permission. Very great of her. So you will see how somebody in that much of pain, when this was elicited,
ഇവിടെ നേരത്തെ ഇല്ലല്ലോ, ഇവിടെ ഇല്ല എങ്കിലും പ്രസ് ചെയ്യുക, വെറുതെ പ്രസ് ചെയ്യുക.
When we re-evaluate, very important that we press the non-painful or non-tender areas to start with before we reach the tender area.
നമ്മുടെ മാറ്റർ ഓഫ് കൺസേൺ ഇതാണ്. എത്ര ഉണ്ട് വേദന? ആ മുറിവിന്റെ ഉണ്ട്, ശരി തന്നെ. ഇത്രയും മുറിവിന്റെ പുറത്താണ് ഞെക്കുന്നത്, അല്ലാതെ അത് നിലവിളിക്കുമായിരുന്നല്ലോ.
It's not that the lady was just a very alpa sattva scenario. The same point, she was like screaming like anything, and that pain was not the lower back ache. Lower back ache was more of a referred pain from a trigger point that's not resolving, and now she's not even screaming, as you can see.
ഉണ്ടെങ്കിൽ ഉണ്ടെന്ന് പറയണം. നല്ല പ്രസ് അടിക്കുക.
I mean, it's very unlikely that somebody would bluff to us when they really want to be healed. The last one.
നിങ്ങൾ എന്നാ ഞെക്കാ ഇപ്പൊ ഇവരെ? നിങ്ങളെ ഞെക്കിക്കോ, നല്ല സ്ട്രോങ് ആയിട്ട് ഞെക്കിക്കോ. നല്ല ഒരു മയം കാണിക്കല്ലേ, നിലവിളിക്കണേ വിളിക്കുകയാണ്, പിടിച്ചു നിർത്തിയാണല്ലോ.
See, sometimes the patient or the bystander may think that the pressure we are putting is lesser than what we put before. It's nice, okay, let our mother or father or family member repress and press more hardly than we have done before ourselves to find the reality of the result. Because the effect is very unbelievable for the patients, very unbelievable for many of them, not for us. So it's best that they also let them verify it.
നിങ്ങൾ ഇത്രയും പ്രസ് ചെയ്യാറുണ്ടോ?
ഇങ്ങനെ തൊടുമ്പോ അപ്പൊ വേദനയായിരുന്നു. For our non-Kerala friends, previously even by this, when I pressed like this, it was very painful. That's what she says. And now of course she is not screaming.
ഇപ്പം പറയുമല്ലോ, സാധാരണ നിങ്ങളെ കൊണ്ട് എന്താ ചെയ്യിപ്പിക്കുന്നത്? എത്ര ദിവസം കൂടുമ്പോഴേ ഞാൻ ഞെട്ടിപ്പിക്കുന്ന അങ്ങനെയാണെങ്കിൽ?
A very important point here, this lady used to get her sister press those areas very often, like a dry press. there's a clear indication that the bad blood, if I use that word, in that area wanted to be eliminated or evacuated.
നല്ല സ്ട്രോങ് ആണോ അടിക്കാൻ പറഞ്ഞു? ഇപ്പൊ ഹിസ്റ്ററി 2 വർഷമാണ്. എത്ര വർഷം? ആ ശരിക്കും അതിങ്ങനെ കടച്ച്
ചവിട്ടി നിൽക്കാൻ പറയും. In our local language, it means she really wanted somebody like standing on that point, that, or rather giving a very strong pressure in that area. This is the kind of disturbance she used to have that would make her request to her sister.
ശരിക്കും എത്ര ഹിസ്റ്ററി? 2 വർഷമാണോ എന്തെങ്കിലും കൂടുതലാണ്? 2 വർഷം. വീഴ്ച എത്ര നാളുമ്പെന്ന് സംശയിക്കുന്നത്?
2-3 വർഷം means 2-3 years history, and there was a history of fall. Anyway, we will. So this is just one of the examples that we have shared here. I think this one procedure is fine. We are already 9:20, and I'll go back to the go-to meeting if that is a key. I think it's still there, no? I mean, you can still see. Do you see the PowerPoint? Yeah.
Yes.
Yeah. Okay.
Yes.
So at least because the most important part of this for me, this presentation was the procedure. I mean, once you get clarity of that, other things are simply literary matter. And the second option I put like cupping. I mean, this is much more easier to do, but you need these many things, so the cost would obviously increase. And this is more standard method. It looks like very clearly, and you see different heights of the blood at many levels. Again, now this we have already discussed. We want the excellence for our friends, academic excellence that gives to a financial smartness. We need to have a socio-medical impact, and things like 2-digit investment. If it can make 3 or 4-digit income, why not? So I just shown the simpler method, and you see how you see the blood is increasing. The point I'm showing 2 of them is that even with this amount of blood, the patient says significant improvement, and of course with even this amount of blood too. So that's why, and this is a kind of blood cutlet that may come up. Ashish, video illalo. Thank you Ashish. And what is a post procedure is the outer save, of course. I mean, when we do these things, let us be very frank with them that the prescriptions of the physician have a lot of importance. This is accelerating from gear 2nd to gear 5. This is what we are doing. And it's very important to make the feedback. You have to tell them, obviously, that we have the review after these many days. And I'm keen to know what's the impact that it made on you, because we need to quantify the results we get. Again, this, I think, I just skipped to that. And again, why I put this slide towards the end, there's a lot of inhibition among doctors. The inhibition is this kind of video would hopefully make it easier. There's inhibition among the public. Why should I do it? Then we have to say, look, boss, these many things we do better than allopathy, and this is a process involved. So unless both doctors and public get convinced, this system will not get popular. That is a simple idea. Thankfully, there's plenty of wet cupping videos and photos and sports people involved in it. That makes it popular. I understand that. But it's good if you could convince at your level. And the entire process that we have shown so far was basically when to do it, you have the indications, how to do it, you saw the video, and where to do it. You already have seen the trigger points, how they elicited. So I think what I would do for you is simple. I'll get to this point. It's nearly 9:30, and I think we have kind of made it sufficient enough for everyone to realize. And let me take back. We have done everything now, and there's something I just skipped there. It is, do you see this now? The satellite? Yeah. The satellite visible? Dr. Vijaynath, do you see me with the satellite?
Yeah, I can see you, sir. I can see you, doctor.
The satellite is there
No,
now?
no.
You don't see that? Okay. That's strange. Let me try another one then. Maybe that helps. The reason is when we do a certain trigger point, there's always a satellite point also that has to be taken care of. Very, very, very important. I see it on my screen. Just if you could confirm. Do you see anything that I'm making it here?
No, no. I can just see you. That's all.
That's it.
You close the presentation, I think so, sir. Have you closed the presentation?
I have started it again. Uh, one second. And now is it there?
No,
I put in the play mode. Even now it's not there.
no, no, no.
That is strange. One second. I think let me start the screen share again. Maybe that helps. Does it come now?
Yeah, now it just it is come now. Yes,
Very strange jinx today, but
just come
anyway,
now.
we are there. So the idea is that when we do the trigger point, it's also very important to get into the satellite trigger point too, because that cannot be left out. Satellite trigger point is that surrounds the nearby area, so it will be something still left out if we don't engage that also. This is one common mistake many youngsters make, so I thought it's very important to represent it. So when is impact happening? The impact, this is what we are looking for. The impact happens within few minutes, easily, majority of the people, nearly 50%. And short-term impact happens in a week or a week's days time, easily 3/4. And long-term, nearly 100% the relief sustains for months and years. So this is what we have to communicate to the person. And this is the impact you have, like Virendra Sehwag does. You really gather the confidence and the psyche of the patient, just as he destroys the opponent's all kind of confidence. This is the way it may look like. So some people feel good that, okay, all my bad blood is out of the system and all they're clear. And I think we don't have to put this video because this is in the internet very much itself, the same screenshots that I had done before, and all the materials required, everything is there as a checklist. And you see the Learn Parasurgical in the website. It's just very self-explanatory. And this we have discussed before in whichever way. Yeah, very important. This gentleman, Dr. Shine Mohan, he's somebody who's propagating the cupping procedures quite a lot. Lots of appreciation and respect for him. Hats off. And if somebody wants to know more about him, his website is there, his phone number is there, everything is there. He's doing a great service to the community of Ayurveda, and he's a fantastic enthusiast. And it's everything is there, as you see on that screen very clearly. For more than 2.5 years, he's very, very vigorously and enthusiastically spreading this procedure of you may call it hijama, wet cupping, Sringam, whatever word suits you the best. It's very important to acknowledge youngsters who are doing good job. And I think this we have discussed before, nothing to do with Sringa. I think our best objective would be to train more doctors. And this website and the entire video would definitely help you to break your inhibitions as much. And dedicated to all those people who teach us, before we finish this, from my side at least, only strength respects strength. Unless you have more knowledge, you can't be strong. And it's very, very important to decide your strength and convey to the public. And I think this is the most important slide for all those who wish to have much more subtler knowledge and much more deeper also. Dr. Sajeev sir is the person who has been, for me, the point of contact and reference whenever I have difficulties. He's a fantastically, popular and effective doctor in this specific Anushastra also, other than the general practice, of course. And please note his number. If you feel like calling him, please do so. And if anyone wants to thank him for whatever he is going to help us in the next sessions, very welcome. I think I will call it a day from my side. The reason I prolonged my presentation was that very unexpectedly and unfortunately, Dr. Ravi Shankar Parvaji sir, my mentor, he could not be in this session. But obviously, he will be in the next. So any questions of that time, we can still try. That's why I wanted to complete in about 1 hour time, but I just slowed it down, and I think I should halt now. If somebody has anything I can clarify, please let me know. And I think there are 34 chats.
I think, yeah, but just 2 queries in it. Before that, if anyone wants to raise any query, please come forward. You can raise your hand and we'll unmute your audio.
I have also seen one.
The 2 queries are there. Before that, we'll go. There are 2 queries in the chat box. Before that, if anyone wants to clear anything, please come forward. You want to ask any query or you need any clarifications. Dr. Saju KB has raised his hand. Please unmute Dr. Saju.
It's more about the video not seen. Yeah. Okay.
Yeah, Dr. Saju, he's been unmuted. Dr. Saju, please ask your query.
Do we need to have a tetanus toxoid like injection before this or after this?
We never did. So hopefully it is not needed. We never did. None of my mentors or none of my friends have ever done it.
Thank you.
I'm looking at, there's a question there I can see.
Yeah, one question is post-procedure care of the local area.
Yes. Yeah, that's exactly. As I mentioned, I was lucky with Murvanna helping me most of the time, but I put the star like betadine. So Dr. Sajeev sir opines that the best impact for him is betadine. There's no one case where it got messed up, because what happens now, first of all, the process itself is not fun getting into it, one thing. And secondly, if there's some reaction, God forbid, there's some kind of what we describe as the pustules formed or pus formation or infection, then the negative publicity is tremendously going to counterfire, personally and also otherwise also. So I think the best thing is make sure that you don't end up in a scenario where the patient blames you. There will be good effect of the procedure, agreed, but many times the patient would blame you for the minor and perhaps affordable, perhaps forgettable or forgivable difficulty they may have. Very important. Dr. Joby George, in points where there's no reddish
spot, how can we find the spot for Rakta Moksha?
No. Actually, the reddish spot is because I was kind of doing the Mardana to find the trigger point. Typically, the patient himself may say the pain is there, one thing, but we get it in our hand. This is the important thing.
I'll intervene. Dr. Priya TP has commented that keep cup for a little more time, then there will be red color. If more inflammation is there, I cannot understand what is what.
No, I will make that. Maybe Dr. Priya TP.
Priya TP, please come forward. Please come forward and share your experience, Dr. Priya. Dr. Priya, please come forward. Yeah. Okay. You have been unmuted. Please share your experience, Dr. Priya.
It was a nice class. Sir, in my practice, in practical experience, if there is more inflammation, then within 5 or 10 minutes, there will be red color. And if some cases, there will not be red color. So if we are keeping more, sometimes within 20 minutes also, there will not be any color change. Then in that pain area, we can prick and we can take the blood from there. So then also there will be much reduction of pain.
Yeah. Actually, the red is not necessarily to happen every time. I showed it for the sake of the way we try to figure out the trigger point. I mean, so long as we get the trigger point very clear cut, it's so easy to do. The point of maximum tenderness is what we are trying to bring out. Simple as that. And because if you see that case specifically, I had 3 cases to show the video in case if one was not enough. The lady was telling that I really want somebody to just press so hard. I mean, the body is willing to take out the blood out of the system. No, that's what we want to encourage, and that's what we facilitate actually. Out of all the procedures of parasurgicals, the most difficult to accept by the patient is the Sringam. And that is why I put 3A star. We may think of a much more advanced set of experiences once we complete our normal syllabus.
And there are 3 more queries remaining. One is from Dr. Remya. Can we do this in sciatica with disc prolapse?
Possible, if only, but no, always the best to do Siraveda first and then only go for it. I've done for situations where the Siraveda is not helping or not enough blood is coming. No, it's not just sometimes possible that the patient is letting out as much blood as much we would like it to happen. That is a challenge. So for that reason, then you still have to do the impact. No, it is definitely doable. Definitely.
Another query is from Dr. Manu. Taking blood thinners for patients who are taking blood thinners, can we do the procedure?
It is not a because a very small quantity, that comes up. A few mLs only. Unlike Siraveda, where it can go up to 400, even 500 ml. Here, so it's a very small, so it is okay. It's okay. But these things you have to always tell to the patient that, it may go out of hand. So a lot of disclaimers need to be signed. Because please be aware of the fact that the allopathy doctors are not really happy about this process. And they do their share of ugly and dirty politics to defame these methods, calling it a barbar style, medieval style. And then patients are also sometimes, fence sitters. They would just, say different things than what they really have experienced.
And the query is from Dr. Arya. The chance of recurrence of pain after the procedure. What is the chance of recurrence of
always
pain?
There, because this is somewhat typically to be succeeded by Snehagni Karma, which is happening in the coming weeks anyway. Not immediately, but if there's some pain still left out, because the Shodhana part is done by the Siraved or the Sringa, the bulk is taken out. But then there's a reminiscent, the Shamana will be taking care of that, and that is invariably Rukshagni Karma or Snehagni Karma. But majority of the I don't know, somebody's making, I don't know, because the sound was
we have muted.
Okay. Yeah. So because I can halt. Let the doctor communicate. I can stop.
I think she doesn't know that the speaker is on. So we have muted her.
Okay, right. Okay.
Continue, sir.
Yeah. So the idea is that most of the occasions it is not coming up. But if it comes up, there is something that person is repeatedly doing in terms of some lifestyle aspect or some kind of wrong procedures of his physical life. If I say physical life, with muscle action and such activity that is causing repetitive strain or injury, which we don't want to happen. So that is why it may be required again.
Then one query is from Dr. Ranjit. So he's asking, is there any precautions taken while doing the pricking in the vertebral area? How much depth? 3 queries are there in one question. Is how much depth we should. What about the pricking depth and site of Siraveda in sciatica? So 3 queries together. Yeah,
actually, precaution is always we are not going more than that urumbu gadigi, that ant effect. So we are making sure that it's as superficial as possible, because we are kind of getting out the capillary blood and we are drawing it like, water from the well. So the least, the best. And it is a matter of practice and it is very easy. That's why I use that razor blade and that ant analogy. And vertebral areas, we are never touching the vertebral area anyway. We are going for the paraspinal muscles area. We are never on top of the spinal straight line. It's the side that we'll be utilizing, the paraspinal area muscles. And the depth is always enough to get that rectum podiua. That is why I wanted to show that video that way. And the site of Siraved is in sciatica, mostly, towards the lateral malleolus, medial malleolus area, and sometimes dorsum of the foot also. But we may have all the theories ready, but the skin texture and the presentation not always be typically textbook version. So wherever there is a situation where we can have the engorged vein, the patient typically tells that sparsha asaishnatva very clearly. Wherever the tenderness is maximum, or the patient tells that the vein pops up when the pain is more, that is the area where we want to hit, or the prick when that vein is straight. And how much gap needed for a second one? Easily 2 weeks. We can wait, no problem. Easily 2 weeks. How can we convince Dr. Roshni Hari? How can we convince the patient regarding the reddish discoloration left after hijama? This is cosmetic, doctor. So this is why I say that we need to show these videos and so many photos, etc., to a patient. That if you are a very beauty cautious person, which is your right and your entitlement, please keep this in mind. This may happen in your case. So convincing is for the patient to convince himself and not we to convince them. That's why I said all the politics and the social challenges along with it, or around it. Pre-preparation, nothing other than what has been mentioned. Dr. Uchita PU, everything that is there, it is conveyed. It's more pre-preparation is the psyche of the patient. And our checklist, as I've shown you in that video, our checklist is very clear cut. Because it is, you need this material, you need this timing, and everything is very clear. As shown in the presentation, and in the website also it is there. Calcaneus per, which one is better, Sringa or Sringa, then Agni Karma, Ruksha Agni Karma. Both are important.
2 more queries have come down in the chat box.
Logic behind Sringa or rectal motion IVDP is more of a localized action, no? The IVDP, the Siraveda is the most common. Dr. Shamir, welcome. It's always a pleasure to have Dr. Shamir with us. Actually, it is more of a Snayu related and the Rakta Mosha connected. That is the way the Acharyas have really mentioned into it. And that is where Prabhaji sir was mentioning, even though it's so-called Vata, this involvement, the Pitta Rakta situation is what prompts us for the Rakta Moksha. And somehow, what we call as our standard Ruksha and Snigdha and the Shita and the Ushna, they are not helping us. Then we have no other option that we have to get into the process of letting the blood out. This is why it is not always a first choice. And neither we like to do it first choice and not the patient likes to do it first choice.
Can we use number 11 blade? That's another question.
Yes. Number 12 is fine too. We need just a small rectum podi, that blood drops coming up.
I think all the queries are over.
Yeah. If there's something, we can always make it next time also, because I know there are a certain set of our doctors who are following it clearly, because it's the continuation of what is happening. So we'll figure out. I'm glad we did not struggle a lot with the video. Yeah. But even if somebody missed some portion in this, they can always have the website, and everything is a website. They are not missing anything.
So there are 2 questions from the YouTube channel. One is by Dr. Sreejith. Sir, by using syringe, what is the time period to stop bloodletting?
Actually, the body itself will stop. The body itself will say, okay, I'm done with it. So it is body deciding. We never decide. Of course,
how will you estimate the quantity of blood to be let out? How will you estimate the quantity of blood to be let out?
We never estimate it because we cannot. The person's body will decide. I've had situations where the whole hijama set is like full, and then that it just kavinya udugua. I don't know what to say that. Overflow. Diabetes, well, if it is in control, it's okay. God forbid, if there is any way, it goes for a infection of any nature, then we had it.
So are there any more queries?
I'm looking at 2. Yeah, Dr. Vijayan. Yeah. I think we had it. All done.
Okay, so
Srivatsar sir has.
How about using the pricking lancet?
Yeah, absolutely fine. Absolutely. Yeah, I just hope that what we did not do in our young days, in final year time, our youngsters can, use that, because 20 years before, this kind of thought was never there. So it's a sign of progress that people have shown interest. At least people know that if they want to learn, there are avenues and possibilities, and public can always be benefited by our endeavors.
Okay, so if all the queries are over, shall we call it a day, Dr. Sreejith? Okay, so that was a mind-blowing session, and if Dr. Ravishankar Parvajay sir was there, it would have been more eventful.
Yeah,
So,
I
but
mean,
still,
somehow the Nimitta happened to be like this, but anyway, sir is always there for us.
but we have a couple of classes remaining.
Yeah,
So
he's there.
once
He'll
again,
be there. And moreover,
thank
if some
all
other
the
we can
viewers.
always catch up easy. So I went
So
slower.
once again, I thank the resource person, Dr. Sreejith, and all the viewers and all the office bearers of AMI for making this session really wonderful event. And we'll see you next week. Okay, that's all for the time being. Good night.